Good morning, everyone. Welcome to Neurology Grand Rounds. My name is Meridale Baggett. I am a staff physician at Mass General and also one of the associate editors of the New England Journal of Medicine case records of the MGH. I'm very excited to have been invited back to Neurology Grand Rounds to share this 100-year-old tradition. The purpose of these is to be able to really highlight the clinical reasoning and the thought process and the approach to patients of clinicians that we really admire. And we have the wonderful privilege today of having a primary discussant joining us. Linnoila is going to be discussing a case for us in the traditional unknown format, which means that all she knows about this patient is about a 2-page summary that I sent to her several weeks ago with the idea that she would think about this patient and walk us through her thought process in real time without the benefit of already knowing the diagnosis. So we're very excited to learn from her today. Many of you know Dr. Linnoila. She did her medical school, her MD and her PhD at the University of Pittsburgh before joining the residency program here at Mass General and MGB. She completed her residency and then did a year of fellowship at Mayo in autoimmune neurology before coming back and joining faculty at MGH, where she was for 8 years. And I know that when I was on the medicine service and I had a patient that I was wondering what could be going on here, I can't explain this. It was always wonderful when she was on the consult service, and I always learned a lot from her. I've learned a lot from her and when she served as a management discussant in CPCs before. So I was very excited when she accepted the invitation to discuss this particular case in the traditional unknown format, and I'm very much looking forward to learning from her again today. Dr. Linnoila will be joined today by Dr. Rapalino, who will be going through radiology, and also Dr. Walker and Dr. Martinez-Lage. But I would like to welcome Dr. Lena Liu, who will be introducing the case history of this patient that she helped care for during her residency. And a big shout out to Dr. Liu for suggesting this case as a CPC. Thanks very much. I'll let you take over and tell us about your patient.
Thank you so much, Dr. Baggett. So this is a 58-year-old woman with progressive confusion and MRI changes that were evolving. She was transferred to this hospital because of progressive confusion and those changes that were seen. And she was in her usual state of health until about 16 months before the current presentation, when confusion and expressive aphasia developed. She was evaluated at another hospital where CTA of the head and neck was reportedly normal, and MRI of the brain demonstrated T2 flare hyperintensities in the left temporal lobe. LP was performed for evaluation, and it showed elevated protein and glucose, but normal cell counts and negative PCR for HSV. A paraneoplastic autoantibody and autoimmune encephalopathy panels were performed on both serum and CSF, and these were without any informative antibodies. SPEP was normal, as were screening tests for syphilis and ANA, and EEG showed generalized slowing without any epileptiform discharges. Thus, a diagnosis of autoimmune encephalitis was considered, and treatment included 5 days of IV glucocorticoids, after which treatment with daily oral prednisone was initiated. Expressive aphasia resolved, confusion improved, but auditory aphasia persisted. Next slide. A CT of the chest, abdomen, and pelvis did demonstrate a 5-centimeter mass in diameter in the pelvis that was composed of fat, soft tissue, and calcifications, after which she actually underwent a laparotomy, and it showed that the path was consistent with a mature cystic teratoma. So she was discharged home on PO glucocorticoids with a plan to taper. About 1 week after discharge, upon decreasing the dose of the prednisone taper, malaise developed and confusion worsened. So she was then readmitted to the outside hospital. MRI of the brain showed improvement in T2 flare hyperintensities in the left temporal lobe, and the dose of the PO prednisone was again increased. Her confusion improved, and the patient was discharged home. and eventually PO prednisone was gradually tapered off. Next slide. About 6 months before the current presentation, her confusion again recurred, so she was again readmitted to the outside hospital. MRI of the brain was again performed, which reportedly showed T2 flare hyperintensities again in the left temporal lobe. A diagnosis of autoimmune encephalitis was again considered, and treatment was initiated with IV methylprednisolone. Her confusion somewhat improved. However, she was again discharged home on the PO prednisone, again gradually tapered off. Next slide. So 3 months before the current presentation, she again had another episode of recurrent confusion. She was readmitted to the outside hospital where a subsequent MRI brain was performed. This time around, there were T2 flare progressive hyperintensities in the left temporal lobe, as well as new T2 flare hyperintensities in the right temporal lobe and the left occipital lobe. She was again treated with IV methylprednisolone, and this time around, IVIG and rituximab were added for treatment. She was discharged to a skilled nursing facility with plans for weekly rituximab infusions for 5 weeks, and then a 6-week taper of PO prednisone. Her confusion improved and did not recur. Next slide. So now we fast forward to about 3 weeks before the current presentation, where she had a surveillance MRI, and this was obtained to evaluate response to immunosuppressive medications. This time, the MRI of the brain demonstrated T2 flare hyperintensity in the temporal lobes bilaterally, with extension to the anterior aspects of the parietal lobes, as well as enhancement involving the sylvian fissures, with evidence of diffusion restriction in the bilateral insular cortices, and spared the subcortical regions. She also had a PET scan CT of the skull base to mid-thighs, which was normal. About 2 weeks prior to admission, she saw her outpatient neurologist, who recommended admission to the outside hospital for additional immunosuppressive treatment based on the results of the MRI brain. 1 week prior to admission is when she was readmitted to the outside hospital, where she was treated again with IVIG for 5 days, but they added the addition of mycophenolate mofetil. And on day 6 of the hospital stay, she was transferred to MGH for consideration of brain biopsy. On the 3rd hospital day at the outside hospital, she did fall while walking to the bathroom, and she struck her forehead. So on arrival to MGH, she reported pain at that site. And next slide. And then we obtained further past medical history of the patient. So that included type 2 diabetes, hypertension, sensory neural hearing loss since the age of 45, as well as depression. In terms of cancer screening, she had had a normal colonoscopy 4 years prior, and her home medication stopped at the outside hospital due to an elevated lactate in the serum of 12.4, as well as her Cellcept, omeprazole, sertraline, TMP, SMX, and thiamine. And there were no known drug allergies. In terms of her family history, she has a mother with diabetes who died of heart disease at the age of 59 and who used hearing aids for most of her life. Her father had died of heart disease at age of 78, and both of her brothers have diabetes as well as bilateral hearing loss. In terms of her social history, she is a non-smoker, does not use any illicit drugs or alcohol, and she previously lived alone, but currently lives in the skilled nursing facility. She also previously worked in healthcare as a technician, but because of all the recent admissions to the outside hospital, had not worked in the last 7 months. Next slide. So on examination, we'll focus on the neurologic exam. However, starting with her vitals, they were mostly unremarkable. Normal temperature, heart rate 76, normal, a little bit hypertensive, 154/90, and satting well on room air. Her BMI is as listed, low at 13.7. In terms of general observations, she did have this auditory receptive aphasia where she was not able to understand verbal speech output, but she did comprehend if you wrote out your questions or typed out questions for her to read. She did have a healing laceration and bruise on her right forehead from the fall at the outside hospital. In terms of her mental status, she was alert and oriented ×3 with fluent speech without any paraphasic errors and able to follow simple and complex commands with both attention and concentration intact. In terms of cranial nerves, they were normal except for a mild anisocoria with the left pupil 2 millimeters larger than the right pupil, but both were reactive to light. Her motor exam was notable for decreased muscle bulk throughout, however, 5 out of 5 strength throughout, and normal tone. And then sensory exam, reflexes, and cerebellar examination were all normal. In terms of notable data, at MGH, she had a CBC with diff that showed a slightly low hemoglobin of 11.3. She had normal BMP and LFTs, and her serum lactate was slightly elevated to 2.6. And next, diagnostic tests were performed. So I'll pass it along to the next speaker.
Next slide. So let's take a step back and see what we're looking at in terms of the case summary here. So we have a 58-year-old female. She's presenting initially at the beginning with confusion and expressive aphasia. Then we look at some of the data that's associated with her presentation. So we know from the MRI of the brain that she has T2 flare hyperintensity in the left temporal lobe. From her lumbar puncture, she's got elevated protein. From her EEG, she's got slowing. And from her body imaging and pathology, she's got a 5-centimeter teratoma. And importantly, after treatment with steroids, both IV and then switched over to an oral taper and removal of the teratoma, her symptoms improved. Next slide. So off of the initial sort of presentation, one would think that this is actually maybe a pretty good story for autoimmune or maybe limbic encephalitis. And I was not privy to seeing the MRI images, so I just had this description. So this is kind of going off of what was described in terms of the MRI changes. So basically, I went back to my teaching slides on limbic encephalitis and so kind of looked at, what would match here and does this, case potentially fit with this? So in terms of symptoms of limbic encephalitis, often the patients will present with short-term memory loss, confusion, sleep disruptions, and mood behavioral changes, hallucinations, and or seizures. So we kind of look at her presentation. Does her presentation match? Well, she certainly is presenting with confusion. And then she's presenting with this aphasia, expressive aphasia. And oftentimes when we see that in these kind of acute or subacute period, it could be consistent with non-convulsive seizures. So symptom-wise, okay, she can potentially fit with this. Limbic encephalitis itself has been long associated with malignancy in the literature. We know that she had a teratoma. So, okay, this could potentially fit. And then in terms of brain imaging, so we're told that her left temporal lobe was bright on T2 flare hyperintensity. So I just pulled in two sample pictures of MRI and of PET scan of patients that have limbic encephalitis. And on the top one, we see T2 hyperintensity mostly in the right mesotemporal lobe. And then on the bottom one, in a different patient, we see hyperintensity in the left mesotemporal lobe. So these are kind of the classic imaging findings that go for limbic encephalitis. And then importantly, when she was treated with steroids, she improved. So congratulations, this is probably the shortest CPC on record, that everybody gets the rest of their hour back. We've got limbic encephalitis, end of story, right? But well, let's advance to the next slide. So those were my teaching slides, but a lot of people are taught to go by what are the criteria that is put out there. So what are the clinical criteria that exist for diagnosing autoimmune encephalitis, and in particular, the subtype of autoimmune encephalitis of limbic encephalitis. So there was a consensus publication in 2016 by Grouse et al., which went through diagnostic schemata for autoimmune encephalitis, and in particular limbic encephalitis. So does this case fit limbic encephalitis as defined by Grouse et al.? So what we know from here is that we need to meet all four of the following criteria. So we need to meet subacute onset. In this case, it's not exactly clear whether this is a subacute process that's been going on for weeks or months, or maybe it could have been more of an acute presentation in terms of the confusion and the aphasia. But I'm giving the benefit of the doubt that we have a subacute onset. The actual criteria for the definitive limbic encephalitis includes bilateral brain hyperintensities. So when she first presented, she only had unilateral in the left temporal lobe. She didn't develop the right temporal lobe until later. So we're actually not able to call limbic encephalitis because we don't meet the second criteria, the bilateral brain abnormalities. And then we go to the next criteria, which needs to be met. And she needs at least one of the following. So she needs to have elevated white blood cell count on the CSF analysis, which does not exist. And she needs to have an EEG, which shows epileptic or slow wave activity involving specifically focally the temporal lobes. And she doesn't meet this either because she has generalized slowing. So, and then the most important thing probably in the, which is not, which may be glossed over in some cases, but it's really important to actually do due diligence and exclude alternative causes. So basically, if we look at my teaching slides, okay, she might fit for an autoimmune limbic encephalitis. But if we go to the actual published criteria for definitive limbic encephalitis, she does not meet this. And this is very important because in the last few years, there's been a lot of attention put out to the harm that's caused in misdiagnosing patients with autoimmune encephalitis. Next slide. So then we say, okay, so she doesn't fit definitive limbic encephalitis. Are we able to at least say that she might have a possible autoimmune encephalitis, which is basically like a lower tier in the diagnostic schemata? So we then look at the Grouse criteria for possible autoimmune encephalitis. So possible autoimmune encephalitis is a little bit less stringent. So this diagnosis can be made when all three of the following criteria have been met. So subacute onset. So again, we're giving benefit of the doubt that we just have a one-liner in terms of her presentation, but we could say that it's she could be presenting in a sort of subacute fashion. And then at least one of the following. So does she have new focal CNS findings? Well, she has aphasia. So yes, she's meeting that. And then, another possibility is that a patient has seizures that were not, previously known. It's possible. So this aphasia could possibly be an expression of seizure. She does not have CSF pleocytosis, but she's meeting at least one of the criteria in the second criteria, and she's meeting potentially the first one. And then the next one in the second criteria, stage of criteria, are that she has MRI features as suggestive of encephalitis. So we're told that she has this left temporal T2 hyperintensity, so we give a check mark there. So then we again get to the same stage that we had in the prior diagnostic criteria, that we've done reasonable exclusion of alternative causes. So this is increasingly important that we are doing our due diligence here, that we are making sure that there isn't something else going on. But if we look at this, in a liberal sense, she does potentially fit criteria for a possible autoimmune encephalitis. But it's upon us that we need to do further examination to exclude alternative causes. Next slide. So then what do we have going for us? That we have a possible autoimmune, possibly limbic encephalitis. So she's in the right age category. She's a 58-year-old female. She's presenting with confusion and expressive aphasia. So she has symptoms that match. Her MRI of the brain, we're told, has T2 flare hyperintensity in the left temporal lobe, so that matches. And then when she's treated with immunotherapy, steroids, and removal of this teratoma that are found, then your symptoms improve. So that all is going for us in terms of a possible autoimmune encephalitis diagnosis. However, doing our due diligence and examining the case more closely, there are things there that are a little bit atypical for autoimmune encephalitis. So we're told that there's this persisting auditory aphasia, and typically when somebody has persisting symptoms, then that actually leads to therapy escalation. That you might pull out the sort of second-tier therapeutics like rituximab or cyclophosphamide or something. Her serum did not have any neural autoantibodies. Well, okay, I have seen plenty of seronegative cases, but you have to really be cautious in those cases that you're kind of meeting the overall picture of an autoimmune encephalitis. Looking at her lumbar puncture, she does not have a pleocytosis, white blood cell count is normal, and she doesn't have neural autoantibodies in the spinal fluid. Again, I've seen cases where they don't have CSF pleocytosis, maybe later into the course, and they don't have the autoantibodies. But again, we have to proceed cautiously. Then looking at her EEG, she has generalized slowing. When we look at what kind of meets criteria and is seen often in autoimmune encephalitis, we see focal or multifocal changes on EEG. We don't see any discharges. We don't see any mention of seizures. So her generalized slowing on the EEG is actually inconsistent with what the type of EEG changes we see in autoimmune encephalitis. And then her body imaging. So we get excited when we see teratomas. We think NMDA receptor encephalitis. We think case closed, fantastic. But this is actually a pretty unusual age for a teratoma and a very unusual age for a teratoma leading to paraneoplastic disorder. So we have to kind of take this with a grain of salt and be a little bit cautious. Again, she doesn't have NMDA receptor antibodies, and she doesn't have GFAP antibodies, which have also been associated with teratoma. So we have to kind of say, okay, well, she possibly has autoimmune encephalitis, but there are a few atypical features here which make me a little bit cautious. And let's take a further step back and look at the picture in its entirety. So next slide. So then as we read through the case itself, it's evolving. So it's not static, it's evolving, and we're seeing some things kind of come through. So basically, despite the teratoma removal, and despite her initial improvement with steroids, and then she's escalated to IVIG and rituximab, she still has progression. So she still has this sort of subacute progression and maybe even going into a chronic progression that's just kind of marching along over time. And it's actually accelerating over time. Initially, it's like many months in between her presentations, and then it's like within the course of weeks. And this is lasting over a year. So this is kind of becoming strange and a little bit uncomfortable for me in terms of, really persisting with this autoimmune encephalitis diagnosis. So then what we look here and the things that we see clinically is that oftentimes she's getting steroids, she's getting better. They taper the steroids, she gets more steroids, she gets better. So the symptoms return, she gets steroids, she gets better. She seems to be responding to immunotherapy. So okay, but what we see over time is that her MRI, initially it improves. So initially this left temporal hyperintensity goes away, but then it comes back. And not only it comes back, but it evolves. And then it picks up the right temporal side and then the left occipital lobe. And then it evolves even more. So it picks up bilateral temporal lobes, bilateral parietal lobes. Then she picks up contrast enhancement in the sylvian fissures. Then she has DWI and brightness on the insulae. So it's just kind of evolving here over time. So despite treatment with immunotherapy, despite escalating the immunotherapy, and her having these kind of starts and stops in terms of improvements in her symptoms, and even her confusion actually resolved. But despite all of this, and then escalation all the way through into mycophenolate, she still has this progression on her MRI. And so this kind of is bringing up some, hints here that maybe, the initial thought and diagnosis of possible autoimmune encephalitis is possibly fitting less and less over time. Next slide. So then, okay, if we stick with our original diagnosis and we say, I really feel that this is autoimmune encephalitis, does this further information that we have fit with it? Well, it could be explained that maybe they didn't give her enough steroids, maybe they didn't treat her for a long enough time with steroids. So, maybe this is why she's having this like starting, stopping, fluctuating course, and it almost looks relapsing, remitting. And actually, this can happen if patients are not treated with sufficient immunotherapy and for a sufficient amount of time. And this is actually the underlying cause for many relapses out there, usually occurring within the first 2 years of diagnosis, is that patients just are not treated for sufficient amount of time with sufficient doses. But then again, we have to remain critical here. So what is atypical for autoimmune encephalitis here? Well, when it's properly treated, autoimmune encephalitis is not typically a relapsing and remitting course. So it's not like multiple sclerosis. It's not like rheumatoid arthritis. When you definitively treat autoimmune encephalitis, it usually does not have this kind of starting, stopping, relapsing, remitting course. And then there's really a lot of radiographic findings in this case, which is pretty unusual for kind of run-of-the-mill autoimmune encephalitis. So keep in mind that 2/3 of MRIs in patients with NMDA receptor encephalitis, and that's something that had to be on people's consideration because she had this teratoma. But again, she didn't have the NMDA antibodies. But 2/3 of MRIs in these cases are actually normal. And the big exception for a lot of MRI changes in autoimmune encephalitis is GABA-A encephalitis. And this is, being worked on, but at least at Mayo, where many samples are sent, it's not commercially available in terms of this antibody. So, could it be possible that she had a GABA-A encephalitis and her, MRI is kind of suggestive of this with the multiple changes? And then, she was given rituximab. She was escalated to rituximab, but then she's still progressing. So then you ask, could this primarily be a T-cell driven process? And could that be why the rituximab isn't working? Maybe, but it really kind of drives us to consider what else it might be. Next slide. So this is an example of what GABA-A looks like. And yes, it's not the best images, but this is actually real life. So there's movement artifact here because this is from a real patient. This is not a textbook patient. This is from a real patient seen by Dr. Lancaster at UPenn. So this is what are some typical findings for GABA-A, that we have these kind of fluffy T2 hyperintensities that are basically found like in the cortical and subcortical regions. They can be all over. But this doesn't really match the description that's given of her changes. Next slide. So then, what are the other options? We have to do our due diligence. We have to think broadly. There are some features here that don't fit smoothly for autoimmune encephalitis. What else could it be? So we know that herpes simplex can target the temporal lobe, but it tends to be very, very aggressive and fulminant. And even with treatment, patients do very poorly. So it doesn't quite fit this description. We know that West Nile infection can subsequently, we can see a lot of MRI changes, but those tend to be quite deep in the basal ganglia, not so much in the temporal lobes and occipital lobes. And we know that toxoplasmosis is usually multifactorial, but it's usually described as these ring-enhancing lesions, which is not reported here. And she really has an unusual time course for infection. It's quite slowly evolving. We don't have any reports of fever. We have a normal white blood cell count. She's not immunocompromised as far as we know. So I'm not so excited about infection. So is it possible that she has a malignancy? Often, when we're considering patients for limbic encephalitis, they actually do come with a differential, at least low-grade glioma on the differential, especially when there's tissue fullness, which we can often see in this setting of inflammation, but also in malignancy. And gliomas can be non-enhancing early with just T2 flare hyperintensity, which is what we see in this case. However, if it was something like a glioma, we would actually expect for its spread to be, basically contiguous. And we see that her lesions jump from the temporal lobes, and then suddenly she has a lesion in the occipital lobe. So that doesn't exactly, fit with a progression of a glioma. So then we think, what other malignancies could it be? Well, CNS lymphoma. CNS lymphoma can be steroid-responsive. It can be multifocal. However, usually the lesions are contrast enhancing, which was only a late feature of her imaging findings in the Sylvian fissures. Next slide. So could it be stroke? Well, we're thinking about she would basically need to have strokes, multiple strokes in different vascular territories. Well, is this possible? Yes. I mean, she could have an untreated atrial fibrillation. She could be hypercoagulable, but there's nothing in her history to suggest this. This could be seen in antiphospholipid antibody syndrome, but her anti-nuclear antibody was negative. And it could be seen in vasculitis. It could be seen in CADASIL. I mean, her changes did start in the temporal lobe. But I think it's quite strange that her symptoms are so reproducible and similar and repetitive over time. If she was getting these massive strokes in different parts of her brain, we wouldn't really expect her to continually be presenting with aphasia and confusion. And then potentially an unusual location to start with in terms of these mesiotemporal lobes, the hippocampi. And then, she improved with steroids, which is unusual for stroke. And then the DWI positivity was only reported as a late finding in her later MRIs in the insulae. So again, kind of not fitting too well with stroke. Next slide. So then what other entities do we know that can lead to T2 flare hyperintensities, contrast enhancement, and DWI positivity on MRI? Could it be demyelinating disease? Well, we're not told that she has periventricular or around the ventricles lesions, and most of them are non-enhancing, and she doesn't have any reported aquaporin 4 or MOG antibodies. So she's not really fitting in terms of the description of where the lesions are and what they look like for demyelinating disease. She doesn't have any antibodies supporting this. Could it be Creutzfeldt-Jakob disease? She does have DWI positivity in her insulae, but that's quite late. And then the time course is quite long, and the EEG of just generalized slowing are atypical for CJD. Could she have a leukodystrophy? There are heterogeneous genetic causes which lead to this, but this is more often seen in childhood. Could she have PML? This doesn't usually enhance, and the patient is not immunocompromised as far as we know. Could she have neurosarcoidosis? She improved with steroids, that we know, but her lesions were enhancing relatively late, which is unusual for neurosarcoidosis, and her CSF white blood cell count was normal, which is unusual for neurosarcoidosis. Could have been a toxic cause. Well, we don't have any known exposures. She has these repeated episodes over time, and it's progressive. So I'm not sure, what sort of toxic exposure would be leading to that, unless it's something she's continually exposed to. Could it be something metabolic? But we are told that the MRI findings are asymmetric. And initially she has this unilateral temporal and left occipital changes. And it's not involving the basal ganglia, which are often involved in metabolic insults, which tends to be symmetric on MRI findings. Could this be genetic? So we'll look a little bit further at this. But let's look at her case a little bit more closely for clues. Next slide. So additional case details when we go back to the case, and admittedly, some of these were in my second reading of the case. So the things that stick out to me from her past medical history is that she's had sensory neural hearing loss since age 45. That's pretty young in terms of this, age-related sensory neural hearing loss. And this could account for her receptive aphasia, that she just doesn't hear the examiner. Then did we learn that her blood lactate level at the outside hustle is 12. Well, we often as neurologists see that and we kind of laugh it off and say, oh yes, she has seizures, no big deal, whatever, I see it all the time. Well, okay. But then her functional status, she's no longer working, she's no longer living independently, yet she's being treated with immunotherapy. This just doesn't fit very well with an autoimmune encephalitis. Then we look at her family history. Her mother died at 59, and her both brothers and her mother had hearing loss as well as diabetes. So the hearing loss is a little bit unusual here. Then her examination, she's got a BMI of 13.7. So she's markedly underweight, which just sticks out to me. And she's got this profound hearing loss. She's got unilateral anisocoria, and nobody is panicking and describing signs of herniation. She's not, being put into the ICU. So I don't think that it's because of herniation. And then she's got decreased muscle bulk. And then her laboratory results show that she's got a persistently elevated lactate. Again, we look at that and we say, okay, that's not that high, fine, but it is elevated. And so next slide. So these additional details kind of point us in a different direction from autoimmune encephalitis. So she's physically deconditioned. She has the low weight, loss of muscle bulk. She's living in a nursing home. So this would point to a chronic progressive illness. Her mother died at 59, which is not very old. Her mother and both brothers also had hearing loss and diabetes. So is this a genetic disorder? And is this fitting a mitochondrial DNA inheritance pattern? She also has cranial nerve involvement. She's got decreased hearing. She's got anisacchoria. Could this be a mitochondrial disorder, which there are all sorts of ophthalmologic findings and cranial nerve involvement that can be implicated in mitochondrial disorders. And then she's got this persistently elevated serum lactate, and at time it's quite high, 12. So does this point to a mitochondrial disorder? Next slide. So then I went to my friend, Dr. Google, and I asked a few questions. So is there a known maternally inherited disorder that leads to hearing impairment and diabetes? Bingo, there is. Okay, well, let's look at it. There's maternally inherited diabetes and deafness, which I've never heard of, but let's explore it further. So mitochondrial DNA mutations, that's sounding good, can cause arrhythmia and CHF. The mother died of undisclosed heart disease, so that could fit. And then you have diabetes, kind of wide range of presentation time, and then it's not always there on diagnosis. This disease, you can have malabsorption. She has a BMI of 13.7. It can cause muscle weakness. She has decreased muscle mass. But looking at the brain changes that have been reported with this entity, they include cerebellar atrophy, which we didn't hear about. And I didn't find clear reports of T2 hyperintensity, enhancement, or DWI positivity. So it's not really matching the MRI findings in this case. So next slide and next question. Can mitochondrial diseases mimic autoimmune encephalitis? Well, I was very happy to pose this question to Google, and I found a recent paper from November 2022, which is titled, Mitochondrial Diseases Mimicking Autoimmune Diseases of the CNS and Good Response to Steroids Initially. Great, fantastic. And then the final kind of conclusion from this kind of fits what we're looking at. We would like to draw attention to a subset of patients with mitochondrial disease initially presenting with signs and symptoms mimicking neuroimmunological. Absence of CSF pleocytosis, which she didn't have, elevated CSF lactate. Well, we don't know what her CSF lactate was, but we know that her serum was elevated, and progressive relapsing course, she had that, should trigger further genetic investigations in search of a mitochondrial disease, even in patients with good response initially to immunomodulatory therapies. So this kind of fits this case. Next slide. So then, thinking back, her imaging findings didn't really fit what's reported in this MIDD disorder. I'm thinking back to residency. I'm thinking of mitochondrial disorders. I'm thinking MELAS, which I can't seem to remember. There were some MRI findings here. So what is MELAS? So mitochondrial encephalomyopathy with lactic acidosis. So she has encephalopathy, this is a confusion. She has the muscle wasting, so she might have the myopathy. She's got lactic acidosis. Does she have stroke-like episodes? Well, with the confusion, it's not particularly stroke-like, but it's focal. She has aphasia. And then patients with MELAS can have brain findings on the MRI that don't respect the arterial territories and can migrate over time. That's kind of fitting her case. Often have a posterior predilection, parietal and occipital lobes, which she did. It can enhance, which they did. Can have T2 hyperintensity, which she did. DWI T2 shine through. She had DWI changes. Seizures are possible in our case. She did actually have diabetes, and patients with MELAS can have it, but it didn't fit in the sense that it usually strikes younger patients and is relentlessly progressive and evident by young adulthood. So 90% of patients will have it by 40 years of age, but then there's still that 10% that don't. Next slide. So then are there shared mutations between this MIDD and MELAS? And looking in the literature, there was this kind of case report of this maternally inherited diabetes and deafness presenting with ptosis and macular pattern dystrophy. So the ptosis is maybe a cranial neuropathy. And the points made here that mitochondrial disorders can cause an array of neuro-ophthalmologic manifestations. She has anisacchoria. And then there's this particular point mutation, the M.3243A to G point mutation in the mitochondrial genome, and the MT-TL1 gene that encodes this tRNA, which commonly presents as MELAS. But many mutation carriers can have a wide range of neurologic, cardiac, endocrine, GI, and psychiatric symptoms, as well as other mitochondrial symptoms, which may account for some of the cardiac findings in her mom. And another syndrome also associated with this particular mutation is MIDD. So we have a shared mutation that can lead to this maternally inherited diabetes and deafness, as well as MELAS. Next slide. So then my final diagnosis takes us away from an autoimmune disorder, and I'm putting my money here on mitochondrial disease, and might she possibly have this point mutation of this MTTL1 gene that's shared between MIDD and the MELAS. And so the test that I would suggest would be a muscle biopsy looking for ragged red fibers, and genetic testing looking at, in particular, the mitochondrial DNA.
Thank you so much, Dr. Linnoila, for that absolutely beautiful discussion. Before we get to the test that you requested, we're going to hear about the MRI that was performed after the patient presented to MGH, and Dr. Otto Rapalino will walk us through that.
Good morning. I'm going to start showing you the radiological studies, looking at the brain MRI presentation and compare it with the previous MRI obtained 4 weeks before. The main abnormality that we can appreciate on these images are signal changes in the subinsular regions. You can see how prominent they were before, bilaterally left more than right. And on the current study and the study presentation, the signal changes have actually decreased, but we still see some changes. We can appreciate some subtle signal abnormalities bilaterally within the subinsular regions. We can also see, at least partially, some additional abnormalities in the bilateral occipital periventricular white matter, as well as in the right anterior temporal lobe. And now we can appreciate fully the signal abnormalities in the anterior temporal lobes, more prominent on the left side. These signal changes overall, they look very similar compared to the previous MRI. The involvement is mostly in the white matter. We can see involvement of the periventricular, central, and subcortical white matter, but also the overlying cortex is affected. There is also mild prominence of the temporal horns bilaterally. These are actual post-contrast C1 weighted images, and we can appreciate the presence of bilateral enhancement within the subinsular regions, left more than right. On the left side is more curvilinear, you can appreciate on the images on the left, and on the right side is more punctiform. There are also some additional enhancing foci within the left anterior temporal lobe. We're now looking at axial diffusion on the left and susceptibility weighted images on the right. This is to show you that there were no corresponding diffusion abnormalities or abnormal susceptibility signal within the bilateral temporal lesions. We also obtained brain MRI spectroscopy at presentation. It was a multivoxel brain MRS using a short echo time. We were targeting the supratentorial brain abnormalities. And this is a magnified spectrum that was obtained from the left posterior corona radiata adjacent to the left lateral ventricle. And we can see the presence of this double peak around 1.3 parts per million, compatible with a lactate peak. The remaining metabolites, including NAA, choline, creatine, they look normal. And there were no other abnormal metabolites. And this is another spectrum obtained from the right posterior lateral ventricle, also showing a very prominent lactate peak as a doublet at 1.3 ppm.
I'll turn it over to Dr. Martinez-Lage to talk to us about the pathology that was obtained after the MRI.
Thank you. So we received a muscle biopsy, next slide, that was labeled as from the right thigh. And here's an initial low power view of the H&E. In the normal muscle, we expect to see fibers that are of similar size and similar shape, and they're usually polygonal. So on first look, there's not a severe abnormality that you can appreciate. Next slide. We did, however, start noticing that there were some small fibers here and there. You can see one here in the center of the screen compared to the one that's right above it, which is large. And in that fiber, you can appreciate that there is some abnormality towards the left side of the fiber. There's some irregularity of the sarcoplasm adjacent to the membrane on the left. Next slide. The Gomori trichrome was very informative in that we identified scattered, not very many, but definitely appearing scattered ragged red fibers. These are fibers that show this irregular puncted appearance of material that stains reddish with this stain, and that usually represents abnormal mitochondria. Next slide. This stain is an immunohistochemical stain that looks for the enzymatic activity of both COX and SDH enzymes, both of which are enzymes that participate in the mitochondrial machinery. In the normal fibers, you will have expression and activity of both enzymes, and that appears as brown for most fibers. When we have loss of COX, of cytochrome oxidase activity, the brown stain is lost, and so you see shine through the blue stain of the SDH activity. So you can appreciate there are several fibers here that appear blue, which indicates that there is lack of COX activity. And in one of them, towards the bottom right of the screen, you can also see that there's punctate reinforcement of the subsarcolemmal area, which usually indicates that there's a proliferation of mitochondria underlying that. Next slide. Electron microscopy actually confirmed this impression. On the left side, you can see there is an accumulation of mitochondria. There's a white area that represents the extracellular space. On the right side, you can see a band of myofibrillary apparatus that's very regular with Z bands and I bands and so on. And then right under that, you can see a collection of abnormally shaped mitochondria, many of which have these optically clear cores. Next slide. And more areas demonstrated these mitochondria with abnormal cristae formation. You can see some that look circular, spiral, and occasionally some of them appear to show some paracrystalline material, even though inclusions were not very prominent. Next slide. So with all of these findings of ragged red fibers, COX negative fibers, mitochondrial proliferation, and abnormal mitochondrial ultrastructure, the diagnosis is skeletal muscle with mitochondrial cytopathy, which may be underlying in a primary mitochondrial disorder, but we're not able to determine whether there's a potential for a secondary mitochondrial deficiency.
Thank you so much. And we'll now turn it over to Dr. Melissa Walker to tell us about the final set of genetic testing and how this patient was managed.
Thank you. So next slide. The genetic testing sent in this case was a next-generation sequencing panel that interrogated a handful of nuclear genes associated with known mitochondrial disorders, as well as the entirety of the mitochondrial genome. And what that study, which in this case was sent from DNA derived from the skeletal muscle biopsy just described, the diagnosis it revealed was an M3243 A to G known pathogenic variant present at 76% heteroplasmy. And I'll explain both of those details further. Next slide, please. So this arrives at a diagnosis of A3243G associated mitochondrial encephalomyopathy with lactic acidosis and stroke-like episodes, or as we sometimes abbreviate it, MELAS, or MELAS. Next. So what is MELAS? So as Dr. Linnoila alluded to, MELAS is a disorder that arises from the A3243G variant in the mitochondrial tRNA leucine 1. Which is encoded by our mitochondrial DNA. The mitochondrial DNA encodes 13 proteins, as well as the RNAs and tRNAs necessary for the central dogma to translate those proteins and produce a functioning electron transport chain. I point out that our mitochondrial DNA is inherited, just like our mitochondria, exclusively from our mothers. So this variant causes a spectrum of multi-system disease. What I've tried to do here is summarize some of the potential findings for you in cartoon format from data produced by the Columbia MELAS Natural History Study. And as you can see, many individuals carrying this variant are going to have sensory neural hearing loss, GI dysmotility, exercise intolerance, diabetes, and notably diabetes that will almost uniformly occur in the setting of a BMI of less than 16%. I will also point out that the sensory neural hearing loss tends to precede the onset of diabetes by about 6 years. These patients can also have cardiac disease, and of course, the often most significant clinically feature, which is stroke-like episodes and seizures. Having a stroke-like episode or seizure and carrying this variant is the definition of having MELAS. Next slide, please. So I mentioned heteroplasmy, and what did I mean by that? As I mentioned, our mitochondrial DNA is present in multiple copies in each mitochondrion, and there are multiple mitochondria per cell in almost every cell in our bodies. That means that there are tens to thousands of copies of mitochondrial DNA in every cell. So when a variant arises in the mitochondrial DNA, it often coexists with the wild type allele, and we call that state heteroplasmy. We call the percentage of pathogenic variant present the heteroplasmy level, though you may hear me use the terms interchangeably during this talk. Next, please. The important thing about heteroplasmy is that it is notoriously variable. And this is data from a single cell study we recently published that shows that even at the level of the single cell, you can see variation from 0 to 100% heteroplasmy within a single cell type within a single patient. Next, please. And then there's even more variability demonstrated across tissues in individual patients. And I'm summarizing data from an autopsy study of monozygotic twins in the cartoon format for you here to make that point. What you can see is, looking at these very closely related individuals, the percentage of pathogenic variant present in any given tissue is non-identical. And then if you look across the tissues in the same individual, there's huge variability. Blood is a particular outlier, and I've highlighted in red for that reason. And that's often why you will see us using tissues other than blood for sequencing in these patients. In particular, for other perturbations of mitochondrial DNA, we find that there may be higher sensitivity for the genetic testing if it is performed from an alternative tissue. Next. So how does this lead to disease? The short answer is we don't fully know. It is postulated that the variant in question alters the tertiary structure of the tRNA, and that causes impairment of translation of those one or all of those 13 proteins that are encoded by the mitochondrial DNA. Therefore, we hypothesize that explains the empiric deficits we see in patient tissues for complex activities, complex 1, 3, and 4, which are the complexes containing mitochondrially encoded gene products. In particular, studies have shown that complex 1 activity is impaired by this variant. Next. But we don't yet know how these biochemical or genetic deficits produce the diseases we see. I will return now to the clinical syndrome. Stroke-like episodes are the largest cause of disability in these patients. Classically, what we tend to see are images more like what I'm showing you here from a case report. What you're seeing on the left panel is the DWI image, and the right is the ADC. In a patient with a MELAS-associated stroke, this is a very classic location to have that finding in the parieto-occipital region. And I'll point out that that's going to often lead to cortical blindness in addition to often pre-existing sensory neural hearing loss. So these patients can end their lives deaf and blind. Imaging findings that should make you think of this include the fact that the diffusion restriction seems highest in intensity within the cortical ribbon itself, though I hesitate to use that term because, of course, that has other disease associations. There may or may not be corresponding ADC darkness. There may or may not, as we saw in this case, be contrast enhancement. It is often said and pointed out that strokes associated with me loss do not necessarily represent vascular territories, and that might also be a clue that this is not your standard arterial ischemic stroke. But I do want to highlight that the fact that a stroke lies within a vascular territory should not exclude me loss from your differential. One important clue, as Dr. Rapalino pointed out, is the MR spectroscopy findings, and what you will typically expect to find is a lactate doublet at 1.8 parts per million, which is shown inverted in this case. Next, please. However, as Dr. Linnoila astutely picked up, mitochondrial disorders can mimic many things, and it is not unprecedented, as we see here, to have symmetrical lesions that can look like other things, including limbic encephalitis, as I'm showing here from this case report. And as Dr. Linnoila astutely picked up, key diagnostic clues that should make you think of this diagnosis are going to be a personal or maternal family history of sensory neural hearing loss and diabetes, because the most common phenotype associated with the A3243G variant is maternally inherited deafness and diabetes, or MID, and those patients can go on to convert to me loss. Next, please. So what do we do for these patients when they have the acute stroke-like episodes? I'm going to restrict the discussion here mostly to the acute phase because I think it's of most interest to the audience here, and we are somewhat limited for time. Next. So as far as FDA-approved therapies specifically for me loss, there are none, and I do want to emphasize that. Everything I'm going to discuss right now pertains to expert consensus support. And the mainstays of that in the United States are EEG monitoring with or without the use of anti-seizure medications, depending on your findings, and acute L-arginine infusion. And this is, for the latter, supported only by level 5 evidence. Next. Next, please. I'm often asked what is the rationale for this acute arginine infusion, and it's an excellent question. We've known for decades that some, but not all, of these patients can have evidence of a microangiopathy on autopsy. This is one image from a series of 14 patients that went to autopsy with me loss in the 80s. You're seeing a peel arteriole, and very similar to what Dr. Martinez pointed out, there is mitochondrial proliferation in the endothelial cells here, similar to in the muscle. She mentioned the COX negative fibers. I will make a point of saying that in many cases in me loss, there is actually preservation of COX positivity, which is somewhat unique amongst mitochondrial disorders. And I want you to hold on to that thought. Next, please. Because the combination of a clinical stroke syndrome and the presence of angiopathy in some patients, 3 out of 14 in this case, has led many people to investigate this vasomotor dysfunction hypothesis. Groups at Columbia and Japan, among others, measured plasma amino acids in their patients. What I'm showing you is data from Columbia with their patients at baseline. And what they found is that citrulline, which is a precursor for arginine, was reduced in their me loss patients compared to controls at clinical baseline. Next, please. The Japanese group found similar findings, but actually with arginine reduced in their me loss patients in the setting of an acute stroke, and therefore pursued further studies of vasomotor function, including this induction of hyperemic flow in the arm and measurement of brachial artery diameter in patients compared to controls. The patients, which are represented in the open circles here, had consistently lower brachial artery diameter in that setting, but had improvement in the brachial artery diameter after infusion with L-arginine. Next, please. So how does arginine come into this? I'm going to summarize quickly for you here the biochemical and molecular pathways thought to be involved. Arginine is a precursor for nitric oxide. Next, it can be converted by NOS to nitric oxide, which can then diffuse across cell membranes. Next, where it can meet one of two fates. One, it can bind COX in mitochondria, or two, it can stimulate guanylyl cyclase to produce cyclic GMP, which in turn will, next please, lead to vasodilation. What the Columbia group in particular hypothesized back in 2004 was that the persistence of COX protein in the COX positive proliferated mitochondria might serve as a nitric oxide sink therefore producing a local deficiency of nitric oxide that might impair vasodilation in these patients in the acute phase in the cerebral vasculature, leading to or exacerbating stroke-like episodes. Next. For this reason, the Mitochondrial Medicine Society, which I am part of in the United States, has recommended that all patients with Me loss be given acute arginine infusion IV in the setting of an acute stroke-like episode. They also recommend oral prophylaxis with arginine following a first stroke-like event, but are agnostic on the use of monitoring levels in this therapy. Next. But I want to highlight for you all that this does remain somewhat controversial. And to do that, I'm going to summarize data from a meta-analysis put out by a group in Newcastle this year. They went to the literature and confirmed that there are indeed no randomized controlled clinical trials for the use of arginine in Me loss. There are 3 open label studies, one retrospective cohort, and a large number of case report and case series. Next. In these, they point out that the use of anti-seizure medications concurrently was quite common, which is, I think, appropriate, but an important confounding factor. Next. 79% of patients in that open level study reported reduction in headache, and that was really the most significant finding they were able to report. Next. And in the case reports, 54% reported at least subjective improvement after receiving the infusions. But based on these data, next, the authors conclude that more data is needed to fully determine the efficacy and safety profile of this intervention in Me loss in the acute and chronic setting. Next. So following up on this particular patient, the year of hospitalization and discharge, they went home to a skilled nursing facility, and they were started on a mito cocktail based on first principles, and as well as oral arginine for secondary stroke prophylaxis. They were seen in clinic as described and the diagnosis confirmed. Next. A year later, a repeat MRI brain was obtained locally, which showed stability of the T2 hyperintense lesions, resolution of the diffusion restriction, and resolution of the contrast enhancement. And at that time, a neurologic exam and mental status evaluation within the limits of a virtual video visit were stable. The following year, however, the patient developed anorexia, was actually not able to tolerate the oral arginine secondary to diarrhea, and had persistently elevated blood glucose and hemoglobin A1C despite medical therapy. The patient also suffered a mechanical fall and broke their hip. Cognition at that time was reported as stable but poor. And then next, unfortunately, the disease progressed for this patient. The anorexia in particular became quite profound. The patient's weight dropped to 68 pounds. The patient had a seizure at the residential facility and was hospitalized locally, ultimately transitioned to hospice care and passed away.
Thank you, Dr. Walker, for walking us through the outcome for this patient. It's a sad outcome, but I think that we've been able to find some good learning in this case. I just want to again thank Dr. Liu for bringing this case forward as a CPC, and thank Dr. Linnoila for taking on the challenge of discussing this case and helping all of us learn both how to think more broadly about autoimmune encephalitis, question the diagnosis, think through when things aren't making sense, and then hopefully for everyone who hears this recording and reads this in the New England Journal, thinking about mitochondrial disorders, even if it doesn't seem like the slam dunk that we learned about in medical school or residency. So thank you very much to all of our panelists. Unfortunately, we don't have any time for questions, but if anyone has any questions, feel free to email them to me and I can send them on to the primary discussants. And thanks very much for your time and attention this morning. Everyone, please take good care. Thanks.